Please welcome Dr. Jerry Bouquot.
Thank you. I wanted to show you there was a time when I was thin. And I know Houston, most people complain about the humidity and heat in the summertime, but for me it's the outdoor restaurants. I put on about 30 pounds in the past 7 years. I tried growing a beard when I was young, and when my son reached a certain age, he decided he was going to try to grow one. He did a better job, but I passed the golden opportunities because when mine grew in, it was mostly gray. And my mother's in her 90s now and giving away a bunch of old pictures, and they're just really strange. And I get along as an oral pathologist. I don't know if you know this, but we tend as a group not to get along too well with oral medicine docs, and I'm one of the few that does do that. But they gave me an award last year, a couple years ago now, and this was a photo. I'm holding a bottle of Geritol, and they watched me grow up. And I bring you welcome from Houston. It is the home of the Texas Medical Center. It's a phenomenal place. The dental school is smack dab in the middle of all this. And it was one of the first two buildings. The dental school and MD Anderson were built by the same contractor, designed by the same architect. And they were built essentially because the head of MD Anderson Cancer Center was best friends with the dean of the dental school. And they had all these trees around their buildings, and they said, let's get the state legislature to call this the Texas Medical Center. And that was in the late 40s. And now it's the 12th largest city in the U.S. We're building another campus a few blocks south. And when all the buildings down there are done, we'll be the 9th largest U.S. city. That's a pretty phenomenal place. Just like the place I spent 30 years in, West Virginia. I still have my home in West Virginia, and I'm 68 now this year, and I'll be retiring there fairly soon. And our book was mentioned earlier. It is still the most popular oral-path textbook and represents probably 90% of the market. The last edition came out 3 years ago. I have told my co-authors, Brad Neville is the first author. He was one of my students at West Virginia University. And I've told him that I'm not going to be part of the 4th edition. We'll let somebody else take over. We did have a meeting when the book first came out where they had an interesting president's reception. This guy came around his business office. His business is called Butt Sketch. And he just goes around to meetings and sketches people from behind. And ours was, they had to have the 4 of us, and of course everybody said we have to call it bookends. And a couple of years ago we had the latest translations in Farsi and Portuguese. I'm not going to talk about this, the NICO situation, especially since apparently it doesn't exist. So I did want to point out, however, that I've recently come across a name that's still a popular topic. I'll be giving a half-day seminar on that for the University of Texas this summer. I'm giving a talk on that to the American Association of Endodontists next month. And they're just as interested in that as you guys are. So it's very much alive and well. I was in San Diego just before I came here, and I just happened to go into a boating store, and they had this sign. Had a lot of pirate stuff, and that's the old title I was using, Bad to the Bone. I thought it was an interesting thing. When you're as boring as I am to listen to, you need some kind of cute title to attract people, and so I have been doing this. Probably the most popular topic I have right now is called the abused mouth, and it's about all of the oral manifestations of drug abuse and even the medications that are prescribed. Well, before I get into today's topic, I wanted to point out that yes, indeed, there is a NICO. This is normal bone marrow, and I think you don't have to be much of a pathologist to see that this is all different from this. And this is NICO. This is NICO. You could just scrape that out as mush. These are normal. I think you don't have to be much of a pathologist to know that there's something going on there. And as a matter of fact, Back in the late 90s, a fellow with this disease who had gotten from Indianapolis, now that I think about it, he had been a trigeminal neuralgia patient for 7 years. Couldn't leave the house really because of his disease. And he saw a bunch of endodontists, and they found exactly where the problem was, and they got him pain-free. But 4 or 5 years later, the pain started to come back. And it was coming back in a different site. This is a lower third molar site. And because he was so afraid of living that life the way he had lived it, he committed suicide. And in a suicide note, he left his head to me. So as a way to honor him, I put together a case report. This is the only autopsy report of NICO. And as a matter of fact, last year at our American Academy of Oral and Maxillofacial Pathology, I presented for the first time a classification system for the microscopic changes we see in all of these NICO lesions. I think bone marrow edema is what I see mostly, but there are subsets, ischemic myelofibrosis. The whole word osteonecrosis has been kind of thrown out, except for totally dead bone, at least when you look at the researchers. And we found all of these changes, and these are names that I think are representative and good, and just got an IRB approval from the University of Texas to go through 12,000 of my old slides to see if the classification system works. And bone marrow edema, I said, is what I mostly see. I can talk to any bone pathologist who deals with hip osteonecrosis, and they would look at these and say, this is bone marrow edema. They're from NICO patients. I don't really use the word NICO all that much anymore. I'm a pathologist, so I'm using the microscopic diagnoses. And of course, the last thing I wanted to point out before I get into my main topic is this, if you don't know it, the jaws are the only bones that have major nerves, sensory nerves in them. Every other bone, I had a year of bone pathology, that's the only reason I know this. Every other bone, once you get into the marrow space, you could scoop the whole thing out without any anesthesia. The only nerves are the very tiny ones that control vasodilation and vasoconstriction. And so we've got the only jaws, the only bones that have some pretty big sensory nerves, whether the teeth have been extracted or not. And if you have, in fact, this kind of ischemic toxic pool, here's a nerve sitting right in it. And it's not so unusual. About a third of the cases are totally hollow. And here we see a nice frayed nerve. Here we see just a tiny little bit of nerve. And here's one with Luxol Fast Blue that stains myelin, and this should be totally blue. And it's only about 1/3 blue because the myelin has been, I assume, destroyed by the disease process. So that may be one reason why we have neuralgia-like pain when it happens in the jaws as opposed to happening in the hip. And somebody mentioned the diagnosis. There are two pretty decent tests even without quantitative ultrasound or the cavitat. And Tech 99 is something that I started proposing back in the early 90s because that's what the orthopedic surgeons were using to diagnose this disease in the hip. And it doesn't give a diagnosis, but it will tell you in somebody with perfectly normal x-ray, it will tell you that there's something going on, either new bone or destruction of bone. And if that happens to be in the center of pain, I think that's a pretty good test. How often is it found in the quadrant of pain? 79%. And that was from a study that the NIH Facial Pain Clinic published somewhere around 6 or 7 years ago. So 79% of the time, a patient diagnosed, not by me, but by people in the facial pain clinic, 79% of the time there is a hot spot with this test in the area of the pain. And their conclusion was this test is not diagnostic enough. I have recently duplicated that and have sent it off to a journal, and believe it or not, we got 79%. We had 117 patients in that study. Another test is one that Bob McMahon has refined. He's from Indiana as well. And diagnostic anesthesia essentially is putting a tiny little bit of anesthesia in the center of the pain and seeing if the pain disappears. And it's just a simple way to figure out whether it's referred pain or whether it is peripheral or central. And another title slide that I started to put together. I didn't realize fire in the bones, I started to use the title. I didn't realize it's a biblical term, so for a good Minnesota Lutheran like myself, I guess that works fine. Those of you who know me as a bone pathologist probably don't know about the other side of my life. There have been two loves, I guess you would call them, research loves, and worldwide I'm pretty well known for this particular one as well as the NICO business. And this is one that started in my early days because it was the title of my master's, or the topic of my master's thesis. It was the first prevalent study of leukoplakia. And I started calling this dangerous mucosa in order to attract people to the courses. But it was really back in the mid-1990s that I used that term in a paper. And perhaps you don't know about it, but there's been a whole revolution. I think some of you must certainly be aware of this, maybe many of you. But there's been a revolution, literally. I'm going to the Fourth World Cancer Congress in China in May, I guess it is, because they're having a whole session on this kind of new technology. And as with all of my seminars, I devote them to my two major mentors and now deceased favorite friends. So when we're talking about dangerous mucosa, it really it's kind of like the NICO situation. You're looking at something and you're not sure what you're looking at, and I just think that if you're a better dentist, a better physician, a better clinician, if you follow this kind of a rule, be suspicious, especially when it comes to diagnosis. You can't make a proper treatment plan without a proper diagnosis. And I can especially say that because I've got the treatment planning clinic in my department, and I'm running it essentially, that in the radiology clinic. And I'm constantly harping on this to our faculty down in those clinics as well as to students. If you don't have a suspicious mind, you will never literally think of. We have hundreds and hundreds of different disease types that we have to be thinking of. And it's okay for a hygienist to say this is abnormal. And most states, the hygienists can't go beyond that. Most of the hygienists I'm familiar with actually can make a good diagnosis, and many of them can make it better than the dentists they work for. But legally, it's the dentist's responsibility. And but even a hygienist is very, very suspicious of a lot of different things. And you can't just see something. Seeing it isn't enough. You have to see it early enough, and you have to recognize that it's something serious. And this is really the main reason. All the cancers that occur in the mouth, or over 90% of them, are right on the surface. And the dermatologists they have no defense if they examine somebody's skin and they miss a cancer. And that has really become the problem with dentistry as well. All the cancers are superficial. If we've done a proper soft tissue exam or an oral cancer exam, then we should have picked it up. And I've defended probably 80 or 90 dentists over my career who were, I think, wrongly accused of missing a cancer. I was wrongly accused of missing a cancer in a lichen planus patient I diagnosed 3 years before the cancer developed, and I gave a letter of warning saying you have to see your dentist every 6 months to make sure this is okay. And unfortunately, he didn't see his dentist every 6 months. But his lawsuit was against me, not the dentist, because I supposedly missed it. Well, it's all squamous cell carcinoma because it's from the surface. Not all of it, obviously, but most of it is from the surface. And when it hits, it hits really hard. If you've had a cancer patient in your practice, you know that massive impact. It's immediate, and all of a sudden you start worrying about all kinds of ramifications, legal and otherwise, in your life as well as the patient's life. And and also we have to keep in mind that this is according to my study. We looked at 25,000 adults, and we found that if you take only the top 25 lesions in all path, the top 25 that were found in this population, oral cancer would be one of them. It's about 1 out of 1,000. And we are talking in oral pathology now about the cost effectiveness of screening, because if 1 out of 1,000 is all you see, you have to see a lot of patients, and most dental practices are 2,000 to 4,000 or 5,000 patients, and a lot of those are younger. So the question is it worth doing these exams? And it definitely is worth doing the exam because we have a life in America, And the number one cause of multi-million-dollar settlements in the dental profession is missing the cancer diagnosis. And that is increasing the number of settlements and the number of lawsuits. And it's hard to believe that anybody would do this, but this was an orthodontist who made 4 Hawley retainers while this tumor, he was taking an impression of the tumor getting bigger and bigger. This was a general dentist who put in over $30,000 worth of prosthetic dentistry, and he just kept scraping this stuff off for about a year and a half, delayed the diagnosis, never sent it off for biopsy. He just thought it was a little irritation from the restoration. And both of these patients did not survive their disease. So we don't want that. We really want this. We want to find it even before it is technically a cancer. In the medical profession, there are a lot of these cancers, like cervical cancer. They assume it's cancer from the first day the cell is dysplastic. They don't wait for invasion. But dentistry is a little bit behind that concept, and we still expect a true cancer to be invasive. So we have pre-cancers. We have to play with words. And a pre-cancer is not really something that's guaranteed to go on to cancer the way we define it in dentistry. It's not a cancer, it's not invasive, but it has a high risk, an increased risk of going on to cancer. And we've got a lot of them. The mouth has probably more of these kinds of phenomena than any other place in the body. More different kinds and the more total quantity. If we look in a typical large group of people, we'll find that somewhere around 2 to 3% will have a precancer in their mouth, or a very early cancer. And not all of these, of course, have the same risk. This is from our textbook. It's a little fuzzy, I'm sorry, but proliferative verrucous leukoplakia is the top one, and this is I wrote this particular chapter, and I made up a table. These are my guesses as to which are the most high risk. And we have some things that are high risk. PVL is a risk of at least 50%. Maybe in some books it's 100%. You are guaranteed to go on to cancer if you have proliferative verrucous leukoplakia. And by definition, that means you have more than 2 leukoplakias in your mouth, more than 2, or you have one that is larger than 3 centimeters. So that is, I guess, the top of the line as far as leukoplakias. And then we have some other things. We get down into hyperplastic candidiasis. We've got question marks, lupus. We're not even sure. There was a time when Colgate switched their soap and sanguinaria leukoplakia came into our lexicon. And now they've taken the sanguinaria out or reduced it, so we don't see that particular type of granular leukoplakia anymore. And we don't talk about this in dentistry, but in ENT offices, they have this idea that Listerine, which we know of as a chemical burn of the buccal mucosa, makes it white like an aspirin burn, a mild aspirin burn. But they think that since it's white, it must be leukoplakia, and therefore it's a precancer. There's a bit of confusion about that, but I don't know anybody in oral path who worries much about Listerine. And all of this is so confusing that the World Health Organization, about every 12 or 13 years, calls a bunch of people together and they have a workshop on oral precancer. And for 4 days we sit around and throw ideas, and bad ideas, good ideas, we debate. And it's really, I was on the last one in London in 2005. Wonderful experience. But you'd be amazed at the difference in opinions that people have. There are people in this group who think lichen planus is not a precancer. And I've always worried about lichen planus as a precancer. And the early studies came out of one of my mentors, Jen Spinborg, that found about 1%, 1 or maybe 1 out of 200 people with lichen planus will develop a malignancy. Well, we had this meeting and we all had a wonderful time, and we came up with a new classification system, and I just sort of kept in the background and did my thing. Most of those people are pretty good friends of mine. But it did remind me of my parents' 40th wedding anniversary, and I thought I'd show you, my hair was a little longer at that point, and this little guy is working on a PhD in economics right now. So, how do we find not only early changes, but ones that are going to be predictive? The hot way of thinking in oral path right now is that not all leukoplakias are actually precancer, because only 4% go on to cancer, right? That makes sense. We're trying to find out what those 4% look like. Well, if we can figure out at that stage when you first see them in your office, this is going to be one of the 4%. Or can we tell the patient this is going to be one of the 96% that we don't have to worry about? We're not there yet. We have a little ways to go, but we do have a lot of activity going on in this arena. And of course, here's what it's all about. We can see changes on the top, and when the dysplastic cells are represented by a kind of a greenish blue, I guess. And all of the dysplasia, as with every epithelium, starts with the basal layer, the stem cells, and then as time goes on, they grow upward, and eventually we'll be able to see a change that we call red or erythroplakia. And a lot of times, in the mouth at least, we get a keratin buildup that isn't shown really on this. But we want to find it at this very earliest stages, at this very early stage, because we think that that is going to be the best for the patient. We'll be able to, there are chemicals, antioxidants mostly, that are being placed on leukoplakias that tend to make them less. The dysplasia level goes down. And so that's a whole other end of the spectrum that is being worked on, and I'm not going to really be discussing that. We really haven't had much to go on until recently, but let me quickly review the previous technologies. I gave a talk in Nice, France many years ago, maybe 20 years ago now, and I was on the very last Pan Am flight ever in the history of Pan Am. It was going back to the United States, and I can't sleep on a plane, and this was an overnight thing, so I had just finished a talk to the World Oral Cancer Congress and decided I'd better make a drawing to try to explain all this. I started with normal and just kept on going until I had this. And that's become a really popular drawing, but it's kind of illustrated here with pictures. A very thin is not so worrisome to me. Thick and granular is more worrisome. And then when we get thicker and even more granular, it's even more worrisome. And finally, when we see pink or red spots, it's worse yet. And the worst of all, as far as risk, is going to be that which has more red and less white. And that's because the cells aren't mature enough to even make keratin. So this is where we're at now, and that's really why I went to Denmark to study, because Pinborg was proposing this in the 60s, and I was doing this in the early 70s. And it was not very highly regarded in this country, and now it's the standard. It has been for about 30 years now. What we're trying to do is, if we can find a clinical way to see where the bad stuff is, then we can use molecular markers, because there's a lot of activity, a lot of money being spent, mostly by medicine, not dentistry, finding different molecular markers in tissue that will tell us this is a bad acting one. And right now I can say that other than human papillomavirus 16 and 18, I haven't got anything I can do to my biopsies. If you send me a leukoplakia, I can just call it leukoplakia with or without dysplasia. Or leukoplakia is a clinical term. We would say hyperkeratosis. So we don't do HPV markers unless somebody requests them, because they're so expensive. That's $200. The biopsy is $130. So it just doesn't seem to be cost effective at this point. But that's where we're heading. And I think maybe in 10 years, when I'm long retired, this will be a standard thing. You send a pre-cancer into the path lab, and there will be a battery of immunomarkers that will be done, just like the medical pathology people do with lymphomas and leukemias. There's a whole battery of immunomarkers to subclassify those things. Well, on the plane up here, I finished reviewing a paper that was submitted to a European journal of oral path, and it answers a lot of questions, so I thought I would just summarize it. This has not been published, obviously, so I can't give you the author, but they have about a 9-year average follow-up of almost 1,400 oral precancer patients. This is including lichen planus, lichenoid reaction, leukoplakia, lupus, everything on that list I just showed you. And if you're into follow-up studies, you realize that this doesn't really, it's helpful to know that, but this is a very valid number. How many person years? You can take 9 years of follow-up for that patient, 5 years of follow-up for another, and you add them all up, and this is a massive 12,000 plus person years of follow-up. It gives a lot of extra validity to this particular study, even though there are no controls. Out of the 1,300, almost 1,500 or 1,400 patients, 204 had dysplasia. These were all biopsied. And you can see most of those are mild. But this is kind of the scope of the problem. Moderate and severe is where that's still the gold standard. If you have a biopsy that says moderate or severe, then you've got a higher risk. And but this particular study showed that out of all of these lesions, 204 had dysplasia, 35 went on to develop cancer. And I think this is going to be the new number. We've been spouting 4 or 5% as the number of precancers that go on to, the proportion that goes on to cancer. I think we'll be saying 3% in the future. And the only things that they found in their study that made a difference is old age, which is older than 65. That's the end of middle age, I want you to know. The sociologists in the past 5 years there's so many people living to be old that they've switched. Now there are 2 categories of old age. There's new old and old old. So I'm still in the new old. That's good. They did find that location made a big difference. It was on the buccal mucosa. About 2% of those lesions went on to cancer. But the tongue lesions were primarily were much higher risk than that. And I think it's probably because there's so much lichen planus, and that's a lower risk lesion, whereas the tongue is more leukoplakia. The lip, from sun damage, the vermilion border of the lip was up to 5%, and the floor of the mouth is 1 out of 10, 1 out of 9 people. So location, location, location. That's pretty important in precancers as well as buying a home or selling a home or having a business. Because the floor of the mouth, we've known for years. In England, actually, they had a different name. They didn't call it leukoplakia if it was on the floor of the mouth or ventral tongue. They called it sublingual keratosis, and automatically they assumed a high risk. Well, their risk level was around 40%, but that was looking at biopsies. And here we have not really a population study, but at least a more representative clinical study. And of course, it did make a difference what the lesion was. If it was a leukoplakia, 7% risk. If it was lichen planus, 1%. But you can see the worse the dysplasia. If you have severe dysplasia, which is 30 out of these 204, then you've got almost a 30% chance of going on to malignancy. And that means you, as the dentist of that patient, should be seen and doing an oral cancer exam probably at least every 4 months in that person, indefinitely. The WHO study that we went through caused a real stir because there was a publication out of Italy just before that, a survey of the literature, that their conclusion was that it doesn't do any good to cut out leukoplakias. The cancer risk is the same whether you remove them or not. And that's pretty frightening. And I just remembered, I'm supposed to give a disclaimer. I do not have any financial interest of a product in my talk or with any of the companies offering grants. Now I've done my work. I guess I do have a little bit of a financial interest because I run a biopsy service, and we do get precancers, obviously. There is no population study. The one I just showed you is the closest we've got. These are the largest, and there's only one that is a population study, and that was one of my Mayo Clinic studies from a while back, you can see. But these are all physician-diagnosed leukoplakias, and 12% of them went on to cancer, and that is knowing everything about everybody in that population. The Mayo Clinic is fanatic about knowing every disease that happens, even if you move away from Rochester, Minnesota. They send you a letter every year. How are you doing? What's happening? That sort of thing. So that's these are probably the worst of the worst, and that's a pretty high risk. All right. So how can we help this? We've got a lot of techniques to go through. I don't want to spend too much time on some of them because they don't seem to be helping us as much as we wanted to. But we're going with cytology, and I'll just go quickly through all of these. Autofluorescence and cellular proteomics are probably going to be the future. Toluidine blue, I've got it as a new technology, but really we've been talking about toluidine blue for 35 years in all path. It's one of the stains that we would use for our nuclei in the lab. And the problem with that, it was only recently FDA approved. It was approved in Canada and Europe for a long time. But the problem with toluidine blue is when you get it in your office, it's just this thing saying swish it around or put it on a cotton swab and then put it over the lesion, then wash it off, and then take a look. The real problem is when you get that same stuff in my lab, it says caution, this is a carcinogen. And you're using it to find cancers. So it's certainly not carcinogenic if you're only using it a few times, but if you have a precancer, you're going to be using these kinds of tests repeatedly, so it has its issues in that regard. However, I thought it was pretty good. This was from a paper of mine back in the early 90s, and these pictures are taken by the oral surgeon who was a co-author. And I don't know if you can see it. It's just a little odd patch of a little redness with some white stuff on top. But it's the oral floor, and I'm an oral pathologist. This is one he found, but he's got a suspicious mind for these things too. And I wouldn't need anything to be suspicious of that. I just tell the patient, come back in 2 weeks. If it's still there, we'll remove it and take a look at it microscopically. But I think if you're a general dentist and you're focusing on the teeth and the gums, and the oral path exam or clinical exam is just something you do to try to be conscientious, you're not being as suspicious, and you might miss something like this. And here's one. This dentist thought this was from just chewing on the cheek, but it turns out to be a form of leukoplakia. In this particular site, candida likes to get embedded. And this is what we would call candida hyperplasia, or candida hyperkeratosis, or candida leukoplakia. And these red patches are not traumatic ulcers. These are areas of erythroplakia, and here was ulceration. And they were positive with the Toluidine blue. So it has some downsides. You have to swish vinegar for 1 minute to break up all the proteins, because they stain as well. Spit that out, put the Toluidine blue on, and then after the dentist or clinician looks at it, they have to swish for another minute with vinegar to clean it all off. And if you're not careful, you're going to have blue on your lips, and that will take about 3 to 4 weeks to get rid of. So it has a little bit of a downside. But the technology is good, and it does find these lesions. The problem is that it has a high rate of false positives. That's why you have to wait 2 weeks and redo it, because any inflammation is going to produce large nuclei, and this is essentially staining nuclei in the mouth. So you've done in the mouth what I would do in the lab, and of course not just neoplastic nuclei are large, but new regenerating epithelium would have nuclei that are large. And also, if you have a lot of extra thick whiteness on the surface, it can't get through that. It's like putting cellophane over on the surface. The dye just simply can't physically get down to where it has to be. So it doesn't work very well. It works really well on red patches, but for every white patch we'll see 80 white patches for one red patch. And back in the early 90s, maybe the late 80s, brush biopsies came into existence in the dental profession. Those of you who are old enough maybe realize that back in the 60s, dentists were doing cytology a lot. I moved to West Virginia University in '75, and they had 6,000 biopsy samples. I thought, that's a phenomenal amount. Only 50 of them were biopsies. The rest were cytologies. And that was from the year before. So that particular oral pathologist just happened to have a real thing for cytology, and he'd talked the dentists in West Virginia into doing that. And then by the end of that time, it disappeared within 2 years of my being there, and I didn't say anything to anybody. It just wasn't working, because we were scraping all these white patches, and we weren't getting the proper cells. Same problem with the Toluidine blue. We got to get down a little deeper. So this was a way to get around that. We'll find it's obvious enough. Once the tissue gets to the lab, it looks the same as a cervical smear or sputum sample. It's just all the same technology from that point on. The idea is to avoid just scraping the surface cells, because we want to find these bad cells down deep. And this is a pretty sophisticated test. They took a pipe cleaner and put a little twist on it and put a little like 3-cent plastic tube, and that's it. And you just twist it until you see some little drop of blood, and you know you're through the epithelium. And then you twist it a little more to get the cells on the brush, and send it off to the lab. And the lab swishes the cells off and puts them on the slide, and either looks at it individually by a human being or by the computers. In medicine, it's mostly computer done now. And you'd think that would hurt, but I recommended the dental hygiene faculty member got a master's in this topic, and she determined that 81% of the patients reported no pain at all. None. and only 4% said that it hurt a little bit, or more than a pinch. Well, this is what the thing overcomes. This is what happens. We now can get that brush down and see some cells lower on. And then, as I said, once it hits the lab, it's the same thing as a regular pap smear. So we can find bad cells intermixed with the good cells. It's a good idea. It's supposed to be for those sort of semi-suspicious lesions that you don't know exactly if you should biopsy it or not, and that is fine. I think this is an okay test technique to be using, but it doesn't really help you identify any lesions. It'll help you find out whether the cells are bad or not, but to make that decision to do something about it, at that stage it's not really helping you. If we do find some atypical cells, then you'll get a grade 3 or high grade, which is not a diagnosis, it's just these are suspicious. And then you do a regular biopsy, and it doesn't really mess up our biopsy all that much. Well, OLCDX is the company that makes this, and they've been pretty aggressive about suing people who make disparaging statements. They've sued 3 oral pathologists for over $1 million each for making comments in listservers. But that's a matter of opinion. Some oral pathology friends of mine just don't think this has any value at all because they don't trust you as a dentist to know where to press the brush. And I don't have that feeling. I think dentists are just every bit as bright and smart in all this diagnosis stuff as an oral pathologist. But because OLCDX has this bit of a issue in the oral pathology field, some of us have decided to go private. We have the same technology, but it's called liquid cytology or liquid-based cytology. And it has some advantages that I'll talk about in a moment. And this is still fairly popular, but liquid-based cytology is just scraping off the surface cells. And so my question is, why are we doing what we gave up doing back in the 60s and early 70s? I mean, pap smears in the cervix were in the 50s, and they're still doing them, right? So somehow that was successful. Dentistry started in the 60s, and we quit after about 8 or 9, 10 years. The reason is molecular markers have come into their own, or are starting to come into their own. And even cells that are superficial will have certain markers that we can find that tell us that, you know, if you look down a little deeper, those cells came from a bad cell, a dysplastic cell, a precancerous cell. And in addition to that, we can add a lot of different things to it. In addition to immune markers, we can actually look at the DNA, we can image it, and right now, other than the dysplasia level, the best test, or the most critical assessment of whether a lesion is going to go on to precancer is from flow cytometry, which we don't do in dentistry. It's a hospital test. And flow cytometry will look at nuclei and tell you whether it's aneuploidy or diploidy. Anything that doesn't have the regular number of chromosomes is going to be aneuploidy, and if it's aneuploidy, that's not a good sign at all. And here would be aneuploidy. We have 2 levels of nuclei, 2 different kinds. And these tests will give you an actual picture of the large nuclei. You wouldn't be able to interpret it, but myself as a pathologist could look at that and say, you know, this is a pretty suspicious nucleus, so let's do more. And you can get, depending on the test you want, you can get lots of images from the nuclei. So that's all available, and I think there's it's really not it's helping make a diagnosis after you've removed stuff from the mouth. And where we're going or trying to go is make all the tests in your office. So we're trying to move it from a lab into your clinical office. And that really is not helping all that much yet, but maybe it will in the future. Visilite came along somewhere in the late 90s. This has a few disadvantages. You also have to swish with vinegar to break up the protein bits and pieces on the surface. So you swish that around for a minute and then spit it out. Of course, we can't call it vinegar. We have to call it acetic acid because it's scientific. And initially, this was a chemoluminescent thing where they have a couple of chemicals. You break the little glass bond or barrier between them, shake it up, and you start to glow. Now you see kids carrying them around in fairs and things like that. But it has a disadvantage in that, and blue light is what is generated, and that's what is needed for this test. It has a real disadvantage in that you have to turn the lights off, and many of us in our offices have one light switch for all the operatories, so it's going to be a little tough on other people working there. And then you just stick this, the lights are on for the picture here, of course, but you just stick this luminescent thing in, or you take, now there's a technique where, the same technology where you have it plugged into the wall, you just stick it in the mouth and shine around, and you try to find areas that are white. That's it, you're finding areas that are white. And it's disposable, they say it's biocompatible, I don't know, well, biodegradable, I don't really know that or not. I thought it was kind of cute because I told you my master's thesis was on leukoplakia. This was a drawing I put together in 1971 as part of my master's thesis. And it's not, they're not stealing the copyright, there's no issue, but it is kind of interesting to have this come full circle after all these years. I was a consultant for NIH, and we did a massive study, and I gave them those, so now they're available for anybody. The microlux is the hardwired version of it. It's a little more powerful, and I think that it also allows the whiteness to be seen a little more. But this also is, let's see, this is a lichen planus lesion, although they're calling it leukoplakia or erythroleukoplakia. It doesn't look like that to me, but with the light, I can see more keratin. The problem is the company claims that it's seeing dysplastic cells. It's really seeing extra keratin. This is a test that has been around for decades in the GYN area. They used to soak 4x4 gauze with vinegar and put it over the cervix and then wait about 10 minutes and take it off. And any keratin that was on there that couldn't be visualized was now nice and white. It's the aceto-white test. So we don't know if it's the vinegar or the light, but the light does help you to see more keratin. And this is kind of disparaged, this technology, by many of my colleagues, but I think anything that helps a dentist or dental hygienist think of cancer and looking for cancer, that's okay with me. And if this is a test they do on everybody, that's fine. I've done several thousand people with it, and I haven't found it useful to me. But remember, I've got that suspicious eye to start with. And this is going to pick up the keratin, not anything going on down below. It's got a lot of false positives. We don't know about false negatives because if it doesn't turn white, nobody's going to biopsy it. Nobody has biopsied it, so we don't know that. That's one of the flaws in the research on this. They've recently added Toluidine blue, which is a good thing, I guess. And because of this particular company, Toluidine blue is now FDA approved for use in the mouth in this country. And you can see it does definitely pick up the red areas, or whitish areas. I'm sorry, the less white areas, which was an ulcer bed. And I don't want to at all imply that everything that is a light is going to work. You have to have just the right wavelength, and you have to do it in a dark room, and you have to do it in a pretty different fashion from the typical diagnostic lights that are out there on the market. Many of them are very good. And this is what I'd like to talk about more than anything. I just presented this. This is what I'm going to be especially talking about in China, and I just presented it to the American ADEA, American Dental Education Association in San Diego, because it's being taught in dental schools now, and we just needed to have a review of all of these topics. But autofluorescence is something that if we turned all the lights off in this room, everybody would see nothing at all, because our eyes can't pick up on that. But you are all glowing. Every one of us has cells with multiple markers or molecules in those cells that fluoresce all the time. But it's such a low level that we can't see it. But if you hit the tissue with just the right wavelength of light, you will get maximum excitation of those naturally fluorescing molecules. And in the mouth, those are mostly the energy-related one, FAD and NADH. And the reason this test works is, as it turns out, with dysplastic cells, they have a different metabolism, and they use up all the FAD and several of the energy techniques or energy molecules. But there are other things, like here, every once in a while, using these lights, you will find pink tongues, and that's bacteria that are producing porphyrins. And of course, we have porphyrins in our bodies as well, but only in somebody with extra porphyrins would we see any redness. Otherwise, we're going to only see the bacteria. And we also have this fluorescence that comes from crosslinks as collagen matures. So if you have something like an irritation fibroma that's all dense collagen or submucous fibrosis, then you're going to have extra fluorescence. And this is becoming a diagnostic tool that goes a little bit beyond dysplasia now. We're just in the early stages. This has only been out about 3 or 4 years, and the VELscope, some of you probably have, was the first product. The light that they use, it's been shown that it penetrates just maybe 0.5 millimeter below the epithelium. And if you have epithelial cells down deep, you will get loss of fluorescence. You'll see a black spot. Because if you don't, the metabolism changes here, and this is where we're going to see things microscopically, but all of the cells above that level have that same metabolic defect. The problem is, sometimes it's inflammation and you have extravascularity, or it's lichen planus, where you have a bunch of lymphocytes breaking up these little collagen fibers immediately under the epithelium. And breaking up those crosslinks means less fluorescence. And so you can't use this test without using your brain. You've got to be able to understand at least how things work, and then also use the regular visual lights as well. So these are the things that produce loss of fluorescence in dysplasia. And this business about vascularity and broken vessels, that actually is probably a good thing in the future, because there are signals that these dysplastic cells produce that go into the underlying connective tissue when they're about ready to invade. And they break up the tissue, get it ready for that invasion, the basement membrane as well as the underlying collagen. So we know all that happens. And this might be a way, if we can just figure out, fine-tune these light sources and the optics, we might be able to tell when a leukoplakia is just about ready to do something worse. Well, dentistry has come late to this. These are all of the areas where autofluorescence is already in place. If you have intubation of any kind, every company that gives you an intubation device has one that has autofluorescence built into it. In the bronchial tree, it's much darker, and they've refined it so much that the computer will color code it. If it's red, that's a really bad precancer. If it's yellow, it's not so bad. If it's green, it's okay. I mean, that's how sophisticated it has become. But in the mouth, we've got somebody with their mouth open, and the ambient light is a problem. Esophagus, larynx, leukoplakia of the larynx is called laryngeal keratosis. People get these tubes stuck down their stomach, up their intestines, in the bladder, and all of those have autofluorescence devices that are being used and commercially available. And there are some for skin cancers as well. Even skin melanoma has a little different metabolic pattern. So we're not alone in all this. Many of my colleagues tend only to read the dental literature, and that's probably the weakest of all the autofluorescence literature. They have to read the whole body of knowledge, which is a couple thousand papers by now. These are the two things designed for the mouth. This is a VELscope. It's about 10 pounds. There's a 4-foot fiber optic light, and you shine it. I'll show you that in a minute. You shine the light from an LED source inside and shine it in the mouth. It's sort of blue light. And then you look through the eyepiece, and that filters out all of the reflected light and allows only that which would be the fluorescence wavelength. And this is their latest version. It's a battery-powered pack. It's a little bigger than the competition. The Identify 3000, Trimera company in Houston is making that. It's a spin-off company from Rice University. And Rice University has probably the best of these kinds of technologies available. So the idea is to shine the light in, get the cells fluorescing as much as possible. And there's a little safety problem. You have to put this, if you shine this light in the eyes for 3 minutes, you might make a person temporarily blind, but that's a lot of time to be shining. in somebody's eyes. So there's a safety goggle that goes with this, and there's no patient safety goggle for the identifying. That sticks right in the mouth. There's a plastic sleeve you throw away at the end, so you don't have to worry about sterilizing it. And it's a very, very handy, both of these are handy technologies, except the Identify, the original VELscope, is very heavy to move around. I know because I had to carry that thing to all the hospitals on the campus when somebody wanted me to use it. And then the operator looks right through that and tries to look at the mouth. The mouth looks like a sort of Army night goggle vision or view, and any place where is a darkness is a place that you have to be especially suspicious of. And then you look more carefully with regular light. It also has a green light, which is supposed to, these are a couple of little hematomas, and this is the same mouth. Green light is supposed to enhance the vascularity, the blood, make them show a little better if you're trying to figure out if this is vascular or dysplasia. And the VELscope has a green light. The eyepiece, there's no eyepiece that somebody has to look at as with the VELscope. You just wear a pair of glasses that does all the filtering for you. And that looks bluish. They've changed a little bit. Now it used to be more violet, now it's more blue. But this is the one that you're worried about. It's equivalent to the green light in the VELscope. And here's a good example from the company in Canada, in Vancouver, that makes a VELscope. By the way, this technology has $15 million of NIH grant research behind it. And it's the largest grant ever given to a foreign research group from NIH. So that is, it tells you something. They've used a little different approach from many of the other commercial products. But this is what the oral surgeon, he outlined it in the mouth, I believe. And then they've used the VELscope and they saw, wait a minute, there's a much larger dark area. So they outlined that darker area on the picture, and you can see it's considerably larger. The oral surgeon would have gone into what looks kind of innocuous, but as an early leukoplakia, would have biopsied in here. But they biopsied 6 places in the dark area, and all of them were dysplasia, either mild, moderate, or severe dysplasia. And I've reached a point with this technology where, even though I've seen thousands of leukoplakias, I don't feel comfortable letting somebody out of the office without using autofluorescence. Is it a screening device to pick up all kinds of things? We don't have that study, and it probably isn't cost effective. But the 2 years that I was in private practice, in my early years, I didn't do what was cost effective. I had a mindset where I wanted to have the best practice possible. So I think I would have been using the VELscope way back when. They're about $3,500, $4,000 each of these devices, and they're recommending discharging $10 or so and have the hygienist do a scan, and the dentist would get involved if there's something abnormal. But this is pretty telling. It's FDA approved for this kind of thing, and recently, 2 years ago, a study was done where they biopsied across the black line, and the dysplastic cells stopped right at that black line. They put little India ink on the tissue, and the India ink can be seen in the mouth, in the biopsy sample. So now it is FDA approved for margins for cancer surgeons. They used to use Toluidine blue, believe it or not. They would just coat that whole area. If they saw a little outlier that was blue, they would take that in their surgical sample. And here we have something that's pretty innocuous. It is just a little bit more red than it's so innocuous it's normal. But this is an area of carcinoma in situ that shows with the green light that there is no vascularity change going on here, but certainly is with the autofluorescence light. And this is one that the company in Canada is calling leukoplakia. I think it's lichen planus. That's my diagnosis, but I can see little filigree patterns. And lichen planus always has some kind of a darkness in the background. And this one they did try Toluidine blue, and you can see it's much more obvious, I think, with these lights than with the Toluidine blue. And here's one also that in the lower part, just behind the lower molar, they used Toluidine blue. And in that particular case, it was just as demonstrative as the VELscope. And that again is lichen planus, although they're including it as leukoplakia. So, if I get a thin one, in the old days I wouldn't even recommend biopsy. I'll just tell the dentist, see this every 6 months and get your fingers on there, feel a little hardness, a little knot. And I tell the patient, the last day of every month, you pull that tongue out and just feel right there. Use a wet washcloth to grab the tongue so you can grab it and feel. If you feel a little knot, then you go to the dentist and we'll get a biopsy of that. I think that's been a good technique so far, but if I do this, and here's a very thin leukoplakia of the pharyngeal wall, the right pharyngeal wall, but now if I see something, it isn't perfectly black, but it's pretty dark, I would now want to go ahead and do the biopsies of this. And the most recent study out of Vancouver shows a 3-year follow-up. None of the, we'll call it autofluorescent negative leukoplakias have gone on to cancer. Only the ones, there have been some that have gone on to cancer, and only those that were positive with this loss of fluorescence had a malignant transformation. And this is one of my first experiences. Somebody from Patterson in Houston called and said, I got 15 dentists, I want to see your VELscope, and can we bring them over to the dental school? And I said, sure, come on over. And I called one of our, that was a lot of paperwork. I called a patient who had moderate dysplasia recently and hadn't had it removed, so she agreed to come over, and she never showed. So we had 15 dentists in the clinic. What are we going to do? So I said, well, hop in the chair, we'll try to contact her. But you, in the meantime, hop in the chair and look at each other. And everybody found the nice orange. Candida looks kind of orange or bright yellow. Somebody had some porphyrin bacteria. But otherwise, the only person that was positive was the Patterson rep. And she had grown up in Galveston on the beach. And even though she's 37, you can see she's got some fairly deep grooves in her lip already. And this is what the VELscope looked like. Very dark here, and I worry more about the darker ones than the less dark, but this has a little dark area here, and very dark area back here. I think we did 3 biopsies of this, and these are the 3 sites of the biopsy, and these were mild dysplasia, and this was moderate dysplasia. And we just did it because we were looking at everybody. I wouldn't have been particularly suspicious of a sun-damaged lip that looked that bad in a 37-year-old. But we've done the biopsies, and now she's being seen, I think, every 2 months by an oral surgeon. Well, here's a white patch that doesn't have any surrounding blackness. That's what I was talking about, no dysplasia. Here's a pretty innocuous-looking white patch. I don't think I would have done anything but follow. I wouldn't have biopsied it initially, but look at how dark it is on the VELscope. And lichen planus, as I said, I don't think this is a great test for lichen planus because there's always a black background. But when I see this, it's time to go. So I'll just, I've got a few more false positives and then we'll let you go. But when I see lichen planus, I actually see a pinkish black. That's the way my eye sees it. It's not the same color as the leukoplakias. That's pure black. And so I don't know, I think we'll just need a bunch of experience. But right now, I don't think this is a test that's going to help us with the lichen planus. We still have to use the clinical parameters, including palpation. And here's the lichen planus. It's not a false positive, really. It's just there's some kind of, either the collagen is broken up or there's increased vascularity. So let me quickly, I just published last year a paper that included what some are calling false positives. I think it's just the technology picks up on other things. But if we have tonsil tags, these little lymphoid, bits of lymphoid tissue, they're often invisible. You don't see them. You use this test and you will see them because they're always black. And then you just have to look a little more carefully and shine your light at a little different angle to see whether it is one of those flattened lymphoid aggregates. And so we do have a list of other things. I said you have to use your brain and you have to know a list like this when you're using these tests. Certainly amalgam is always going to come out black. Melanin absorbs all kinds of light, so that will come out dark. About a third of the geographic tongues I've seen are pure black, but we know it's geographic tongue. We know that's not a precancer, so we just hold on to that. A little bit of mild chronic cheek bite, not really very obvious here, but it shows up here. A little mild rubbing, tongue thrusting with a little slight increase in darkness here. And then any telangiectasia, hemangioma, hematoma, anything like that. Blood has hemoglobin and that absorbs light extremely well. And these little inflammatory areas around the salivary glands in a cigarette smoker or pipe smoker, they show up very nicely, but that's just a pattern you get used to after a while. And this is one of those lymphoid aggregates. You can just barely see the way the light shines off of it, that it's maybe sticks up 0.5 millimeter or so. But it's pure black. Virtually always it's pure black with this technology. So I just want to re-emphasize the fact that we don't want this kind of thing for our future. We want to have something a little bit better than that. And since we're in the early days yet, if I was going to get something in my office, it would obviously be a VELscope or an Identify. Both companies are very honorable companies, but of course sometimes salespeople will build up a product more than it scientifically is deserved. But since there is no conclusion, I just thought I'd put a bunch of sayings up here and let you know. First of all, Matz's maxim, a conclusion is a place where you got tired of thinking, and we're still doing a lot of thinking with all these technologies, but I think when the dust settles in maybe 10 years, these products will still be here. The autofluorescent products will be here and more refined, and the oral CDX will be here. All the rest will probably fade away. I guess I'm coming back for questions, and it's lunchtime, so thank you very much.